All right. Thank you all for coming. It's great to be back. I think this is my third year doing this. And it's a shame this year we're not going to do it all in person. We're going to do it recorded. But I'm going to talk a little bit about today's topic, which is about cancer care, but it's really about how we can do better as a county hospital. Okay. So I want to get started by saying I think we do a lot of great things in oncology, particularly the staff here at SFGH and the nursing staff at SFGH and the social workers and all the people who work on the team. Some of those things include we provide comfort for people, our patient population, who really benefits from it and needs it. People who are in tough times and tough situations who benefit greatly from having such close follow-up, close care, and such attentive staff. I think we provide guidance for people who may not know what they're expecting next. And we do a great job here in SFGH of helping people think about what the next step might be in their cancer care. And I do think we give a lot of good drugs. We have a lot of curative treatments we've been giving. I know many of you have taken care of some of the patients that we've been seeing the last few months, people with like Burkitt's lymphoma, and we've cured them, people with non-Hodgkin's lymphoma, we've cured them, and people with breast cancer who had surgery and got some chemotherapy and are doing really well. So we definitely have many patients who benefit, and if things go really well after about 4 or 5 years, they stop seeing us in clinic. And so there's so many success stories to what we do here. At the same time, I think, each year I practice here, I start to think we do some things that I also feel concerned about. And to me, those concerns are basically about things that I'm not sure it's the best use of our time, best use of our limited resources here at a county hospital where we have patients with such dire needs on the one hand, and on the other hand, I find us doing things that are sometimes low value, sometimes may not really add that much, sometimes are really futile, and that concerns me in a place that I think for the most part is pretty cost conscious. So hype. You know, one of the things I think is the most dangerous thing in oncology is how do you balance enthusiasm, which is important and which is really well-deserved, and when does it cross into hype? When is it sort of unjustified, goes over the top, and I think people are saying much more than what the evidence shows. Well, a few years ago, I came across this figure. This came out in one of the magazines, journals, that's what they call them. It was an advertisement for a drug called Afinitor, or everolimus, and we have a few patients here on everolimus. And it was the final survival results from a trial called Radiant. My laser pointer doesn't show up on the screen. And what you see here is that the authors show you really nice and color-coded that if you take this new drug, you live on average 44 months, whereas if you didn't take the drug, you took placebo, you live 37.3 months. And they write that's a clinically meaningful improvement in overall survival. So there it is, that benefit colored in yellow, clinically meaningful, they say 6-month benefit. I noticed the fine print. The fine print on the same ad said, not statistically significant, but clinically meaningful. Actually, statistically, there's no difference between those two curves. They just happened to highlight it because the number went in their favor. Not statistically significant, but clinically meaningful is actually kind of a made-up phrase. It's not true. If it's not statistically significant, then there really is no cause to say that you've observed a legitimate difference. And whether or not it's clinically meaningful really is kind of a moot point. We didn't really even know that there is a benefit to this new drug. They just happened to color in those curves because they looked in the direction that they wanted them to go. You know, a few years ago, we made this about the ASCO conference, which is every year in Chicago. And has anyone here actually been to the conference? No. Okay. It's 40,000 people gather in the McCormick Convention Center, and you know, it's really kind of a hype fest. All you hear about is breakthrough, breakthrough. A few years ago, we made this bingo board to talk about the kinds of words you'd hear at conference. Unprecedented. Everything was unprecedented. Personalized. Breakthrough. Transformative. Wearable. Everyone cared about wearables. Miracle. Well-tolerated. NGS sequencing. Everyone's getting sequenced. Game changer. Inflection point. Real-world evidence. Big data. Might work in combination. That's what they say when it doesn't work. They say, well, it doesn't work, but it might work in combination. If you keep trying, you might find something. I also think that, you know, as a profession in oncology, I wonder if sometimes that, you know, we can simplify things, but is there a point where we're dumbing it down too much? I worry that most practicing oncologists They don't have time to read the full papers that accompany all these new drugs. Sometimes they're just going by what you hear at a conference presentation, what you might hear from your friends or colleagues. But I think we might have reached maybe one step even beyond that. The New England Journal of Medicine, which is the premier medical journal, just announced a new partnership with an internet comedian doctor, Dr. Glaucom Flecken. I find him funny sometimes. A new partnership where you get a comedian who's going to summarize the results of practice-changing studies in maybe a minute and a half for the audience of New England Journal on TikTok. And to me, I think maybe you could read a few papers. I mean, maybe instead of getting an internet comedian to summarize it in a 90-second video, it might be worth it to dive in a little bit deeper into what actually they did in the study, what they actually found, and what are some potential limitations. Because I think this is just parroting the abstract, and I've watched one of these already. It doesn't really go beyond that. I noticed something that ASCO at the conference, they like to feature the voices. They got all these people who they recommend you follow. They call them featured voices. And they tell us that if you don't go to the conference, you follow these people, you're going to get, a lay of the land of what's happened at the conference. We actually looked through all of the tweets of these people during the ASCO conference. And my first question was, how often do they discuss research presented at that conference, which is presumably the reason why you go? And we found out of 810 tweets, 200 some, about 28%, discussed research at the conference. But what was more interesting to me was if you compare that against the number of selfies or photos of each other they're posting, they got 35% selfies and photos. So we really got more selfies and photos than we actually have research discussion. And to me, I think that maybe oncology is getting too far down the influencer hype train and has forgotten that it's really a field where it kind of helps to talk about the research. When they do talk about the research, we find that 97 out of the 136, 97 speakers or 97 tweets are supportive of the research presented, and only 13 are critical. In other words, they tend to just kind of praise what they see and not really put it under a critical lens. This is unpublished. We'll publish this soon. A few years ago, I noticed that every time I'd go to the conference, people were calling all these drugs miracles, game changers, and cures. And there was a whole list of drugs they kept calling a miracle. It's a game changer. It's a breakthrough. It's revolutionary. It's groundbreaking. Turned out that 50% of the time that people were using that language, the drug was not approved by the FDA. And 14% of the time, that drug had never been given to a human being before. There's no human being data. It was a game changer, but for mice, not for people. So it was a mouse game changer. And again, I think this is just an example of where oncology has gone too far. It's, internet comedians are giving us summaries of research. The featured voices are just posting selfies. Everything's a game changer, and it's mostly been not approved by, half of it's not been approved by the FDA. I think enthusiasm is great, but hype is when we go a little too far. So, one of the things I think is interesting about county hospitals and places like the VA where I've worked is that, we really have a fixed budget. Much of the care we provide is really care that's been funded by the city or the state government, and this is not a place where we have money to burn. We're always looking at the budget each year. In a place where you have a fixed budget, I think the things we should do are the things with the biggest impact for the amount of money you spend. And to me, one of the more problematic things we do is screening. And I'm going to give one example, lung cancer screening. I think we screen people who kind of just want to be left alone. A few years ago, I was taking care of a guy who, I'm going to tell a story a little bit. He came to me and he told me, the first thing he said is, listen, doc, the only thing I want, I'm an old guy. The only thing, I have no relatives. I'm not married. I got no kids. The only thing I want is just to work on my car. I just want to work on my car in my garage. That's all I want. I don't want to be bothered with too much of this medicine. So here's his story. I call him an improbable 74-year-old. He was 74, and he was thin. He wasn't just a little bit thin. He was rail thin. He was like, you could blow him over if he caught a breeze. In part because he was a smoker. And he wasn't just a person who smoked a little bit. He had smoked a lot. He smoked 3 to 4 packs a day through most of his life. So he had smoked about 100 pack years or 200 pack years of smoking history, which puts him on sort of the high end of smoking. And age did not slow down his smoking. He still enjoyed cigarettes from the moment he woke up till the moment he went to bed, and he worked on his car in his garage. He came into the hospital one day, and the primary care doctor said, what you need is you need a CT screening scan to make sure you don't have lung cancer. You got a heavy smoking history, you're the right age, we're gonna scan you just to make sure you don't have lung cancer. Again, he felt totally fine. The first scan shows, actually, of course, they're gonna find some spots on the scan. There were several concerning spots, and in the years that followed, a few were treated. He had a needle biopsy of 3 of them, and 1 actually had adenocarcinoma, cancer. He had a PET CT and an EBUS, which is another invasive procedure. He underwent a lung resection, and then they gave him chemotherapy for a few months just to lower the risk of that cancer coming back. But a year later, there was a different nodule in the lung that they had found that also started to get bigger, so they got more CAT scans for him. And this time they biopsied that, and they found small cell lung cancer, which is thought to be a more deadly and aggressive type of lung cancer. This guy, he gets surgery again. This time he gets some radiation on top, and he gets more chemotherapy. So he's gotten chemotherapy twice. And then when he came to see me in clinic, he had a 3rd nodule that had started to grow, and that biopsy showed a different cancer, yet a 3rd different cancer, and he had just had surgery, and the tumor board was discussing whether or not we should give him a little bit more chemotherapy. Because if the first 2 courses of chemotherapy didn't work, what will work? The 3rd course. The 3rd course is going to solve all the problems. If the first 2 don't, the 3rd one is going to... To me, this is what I think craziness is in medicine, where you got a guy, and he's literally telling you, I just want to work on my car. But because he had that first scan and the dominoes that followed, he's had scan after scan after scan, surgery, biopsy, radiation. And if we're perfectly honest, we don't really know for sure we've extended his life. I mean, you might think we did, but we don't know for sure, and I'll show you a little bit of data why. In this randomized controlled trial of lung cancer screening called Nelson, which supports screening, everyone likes to talk about if you get lung cancer screening, you're less likely to die of lung cancer, and that's shown here with the blue and the orange bars on the left. There's a 2% versus 3% chance of dying of lung cancer. But what they don't talk about is that there happened to be an imbalance in dying from other cancers that went the other direction, and if you just look at dying for any reason, it looked like CT screening for lung cancer did not improve mortality. And the same thing was true in the other lung cancer screening trial, the NLST, in their follow-up analysis by Paul Pinsky. So what's my point here? My point here is we're bringing him in to do this, and if he asked us, do you have evidence that I'm going to live longer as a result of getting it? I think the only honest answer is actually we don't. We don't have that evidence. This is a paper that came out last year by Michael Bretthauer, where he took all the cancer screening tests and he tried to calculate how many days of life are you gaining by participating in this. Now, if you get a sigmoidoscopy to prevent clips and polyps, you do have a significant improvement in days of life, but he calculates something on the order of 90 to 180 days on average. But for lots of the things we do, including lung CT screening, it's hard to know if we're actually making a difference in terms of how long you live, and that's what his paper is supposed to show. There's a lot of uncertainty. So, I feel like it would be a very different situation if the primary care doctors and people who refer for lung cancer screening told the patient this. He said, listen, if you want, you could come in and get these scans. And if you participate in these scans, we might find something and cut it out, and we might extend your life, but we also might find something that was never going to hurt you, that was actually probably a little bit slow growing, and by chasing it down with biopsies and procedures, we might end up harming you. And we actually don't know for sure which is more likely. We do know it's going to take up a fair bit of your time, and you're more likely to become a patient, but I don't know for sure you're going to get a benefit from that. Do you want to do it or not? And I think if we told it to him that way, he would say, well, I just want to work on my car, which is kind of how he started. Okay, so my first point is that I think we are, if you're at a county hospital and you got a fixed budget and you got a lot of people who need a lot of services and they have real explosive disease and they feel unwell, trying to go hunt for people who don't have cancer they can feel with screening, I think it's not the best use of our limited resources. And I think that that's a way in which our priorities are misplaced. Okay. My next point is I think we give expensive drugs that I think are marginal. Now, some of the drugs we give are great. I mean, I don't want to get into too many specific cases, but in the last few months on service, I've seen many really great cases, great stories where somebody had testicle cancer, we gave them a curative treatment. Somebody had resected colon cancer, we gave them Folfox and probably increased their chance of cure. And we had a bunch of patients with lymphoma come in over the summertime, and we did really well for them. But at the same time, there's so many new drugs that we end up giving a lot of drugs that are just expensive but may not make people better off. So this is an analysis that we did of 392 drugs approved by the FDA. And the first question is, when the FDA approves the drugs, how many times do they approve them knowing that you live longer, you get a survival benefit? The answer was just 87 out of 392. We know you live longer. When we don't know that, we know that they either shrink a tumor, you have a response, or you delay the time until the tumor gets worse. We improve the progression-free survival. What happens to those drugs over time? Well, it turns out that 28 out of 392 are withdrawn from the market. They actually turn out not to have a survival benefit. They got a big problem. Of the other ones, some are tested for survival, and some of them do have a survival benefit, 38 more. So there's a total of 125 that we can say for sure make people live longer. But the rest of them, 109, don't have a survival benefit they don't have a survival benefit, or 130 are not tested for survival. We don't know if they have a survival benefit or not. So the overall result is there's about 260 out of 390 drugs that we just don't know if you'll live longer as a result of getting. So to me, this uncertainty is kind of a problem, and it wouldn't be a problem if the drugs cost $5 a month. I think it's only a problem because the drugs cost $200,000 a year, $20,000 a month. I just don't know how we can justify spending $20,000 a month on someone's treatment. Sometimes they take 2 drugs. Now you're talking about $40,000 a month, and you just don't know if they live longer. Meanwhile, we have so many needs. We need somebody to drive the patient to the clinic appointment. We need somebody to go to the patient's house and maybe help out with the dishes or help them around the house. And you try to get funding for that, you can't get a dime for that. That's the hardest thing to get funding. So we're spending all this money on these drugs, but we're not spending it on care for people. And that to me is one of the big problems of, I think, American medicine. Why do we spend on the drugs? I think the drug companies have better lobbyists than the people going to your house and providing you care. And that's the real reason. So this is something that I see we have started to do here, which I thought was a bit unusual. This is the ADORA study. What do they do in this study? They take people with lung cancer, and the good news is the lung cancer is not metastatic. It's not widely spread. It's just in the lung area. And usually we can cut it out fully, and we can think about giving you some chemotherapy to lower your risk of recurrence. That's what we do for these people. Local lung cancer, these people may have presented not from screening, but with a cough, or they felt like a little unwell. They got caught with lung cancer. We cut it out. They're getting chemotherapy. Well, the drug company, the makers of osimertinib, wanted to test whether or not giving them several years of treatment of osimertinib for up to 2 years would extend the time until their cancer came back. And so they took these people, they randomized them to osimertinib or placebo. All right, that's what they're doing. And here's their result. This is the time until the cancer recurs or you die. And what it shows is in the osimertinib arm, you have a longer DFS than in the control arm where you don't get it. So it looks like it's a success. We got to give all these people osimertinib, they take it for many years on end, and we slow the rate of recurrence at $17,000 a month. Okay. Well, the study has some problems with it. One of the problems with the study is that to enter the study with local lung cancer, one thing we do here, and in all hospitals I'm aware of in America, is anybody who's got lung cancer of a certain stage, you got to do a PET CT and an MRI brain just to make sure it's not already spread to the brain or gone somewhere else. They didn't do that in this study. They said that the study was running in places where we can't afford to do the staging scan. But to me, I said, if you can't afford to do the staging scan, they're never going to be able to afford $70,000 a year for osimertinib. So you shouldn't really be doing your study in places where you can't afford the staging scan. Or if you do it there, you should just pay for the proper staging scans. If you enroll people with metastatic disease in the study, it makes it more likely that osimertinib will win. And it's also another problem because when this study was running, we knew that people with known metastatic disease should get osimertinib. They should be on osimertinib if they have brain mets, and if they have relapse, they should get osimertinib. The study we really wanted to see was to take these people with local lung cancer, cut it out, in everybody who you cut it out in, give them osimertinib. In the people you don't cut it out in, or you don't give osimertinib to, you follow, and they should get osimertinib when they have relapse disease. And then these people get chemotherapy, they get second line, these people get second line chemo, and we measure how long you live, overall survival. So really it should be a trial of giving lots of people osimertinib versus giving fewer people osimertinib at relapse. But the problem with that study is they didn't do this. They did this in like about 40% of people. And they said, well, it's not available in the places we ran the study. But did you know who actually could have made it available is the sponsor of the trial, AstraZeneca. They got tons of it. So they could have given it to people in the control arm. They chose not to do that. I saw somebody say, this is kind of the shameless hype I see, all of the people who relapse pay the same price or more with inflation. So, you're really not paying that much extra by giving it to everybody. Well, that's a faulty argument because they actually take it for much less time, and many of them don't relapse. And so I actually calculated it and showed them that it costs millions of dollars more to just give it to everybody rather than just give it to people who relapse, and maybe $40,000 per person extra. We did another study where we took all these new drugs that we are incorporating here into the county practice, and we looked to see how much money does it cost to prevent one recurrence of cancer. We looked at pembrolizumab in melanoma, nivolumab in bladder cancer, durvalumab in stage 3 lung cancer, the list goes on. This is the cost to prevent one recurrence. $800,000, $900,000, $910,000, $1.4 million, $1.8 million, $2.6 million. To me, this strikes me as very kind of crazy for us to be doing at the county, that we're spending $2 million on drugs to prevent one relapse when we could take that money, and in many cases we don't even know if people live longer, truth be told. And we could take that money and use it for so many more social workers and nurses and staff to provide care for people who have needs far beyond, just the recurrence of the cancer. And this to me is, I think, one of the ways in which our priorities are really messed up. Okay, I'll skip this point. But the point here I want to make is, in this study, you're supposed to get chemotherapy before you take this. They didn't even do that in everybody, and the people in whom and they didn't even do that in anyone. That's my point. Okay, and this is the figure that showed that they're getting the correct treatment after the fact in very low numbers, only 79 out of 184 people. Okay. So when you go to the ASCO and it says ADAURA is the first phase 3 study of targeted therapy in the adjuvant setting to demonstrate a survival benefit, that's only in the context of a control arm that didn't get appropriate care. When they say it firmly establishes adjuvant osimertinib as the standard of care, I think that's dishonest. It doesn't establish that at all. And individual hospitals and health systems should ask if it's really a priority for the people who are there. They say ADAURA is a groundbreaking trial in lung cancer. I would say it is a problematic trial in lung cancer that didn't do the right thing for the people in the control arm, even though the company could have made the drug available. So I disagree with all these conclusions. And then when I go on Twitter to get the interpretation of this study, ASCO is telling me to follow people who are praising the study or tweeting selfies and not actually being critical about the study. And that, to me, I think is the problem with the cancer ecosystem. I'll give another example of things I think we do that don't make a lot of sense to me. Cholangiocarcinoma is a really bad cancer of the gallbladder. And every once in a while you catch it and you can cut it out, and we give people Xeloda. And we have them go home with the Xeloda prescription. And the reason we do that is that the NCCN guidelines for the biliary tract cancers recommend category 1, means quite a recommendation, Xeloda. Okay. But if you look at the footnote, it says the study actually shows overall survival did not reach statistical significance in the intention to treat analysis. Just like the first figure I showed you. Clinically meaningful, but it's not statistically significant. But that's another way of saying, I don't even know if you live longer by taking this. We don't even know if it works, and it's recommended. And it turns out something very interesting. This is a paper we wrote about this. If you look at the study, the reason why doctors like it is that it has a hazard ratio that looks like it's going the right direction, and the p-value is 0.097. We usually look for 0.05 or less, 0.05 or less. It's bigger than that, but they say it's not a lot bigger than 0.05. It's, some people say, close enough. But what people don't tell you is when they ran the BILCAP study, they ran 2 other studies at the same time of different drugs, gemcitabine, gemcitabine oxaliplatin, and these were the p-values. So, what does that mean? The p-value tells you the probability you would see the BILCAP result or a better result for Xeloda, assuming it doesn't work at all. And that is basically 1 in 10. But what's the probability you would see a result like this, assuming it could have happened in any 1 or more of 3 trials? Because you had 3 times you're throwing the dart at the dartboard. What's the probability that if you throw 3 darts, one of the darts is going to hit the bullseye? It's better than just 1 throw, right? And so we calculated that, and it turns out to be it's about a 1 in 3. There's a 1 in 3 chance that if none of those drugs worked, you would see a result that looks just like this. So to me, I think, if you're talking about a hospital where our patients have so much needs and our budget is fixed and there's a 1 in 3 chance you would see this kind of result assuming this drug don't work at all. To me, and the drug has like real side effects and is toxic, to me, it's kind of unacceptable to be giving chemotherapy to somebody who has no visible disease and ostensibly no symptoms from disease based on this study. Like, it's a negative study, the totality of the evidence is negative, it's costly, and there are better things we can do with our money. And yet we do it because we're just kind of following the guidelines. Okay. I thought one thing that would interest you is we talk so much in oncology, the doctor's always talking about the patient had a response. Is he responding to therapy, not responding? What do they mean by that? Well, it turns out what they mean is that if you initially measure the tumor, it has a diameter, a cross-sectional area, and a volume. Response is, at some period of time afterwards, you scan the person, and that diameter has become 70% or 30% of what it was when you started. That's considered a response. So if it's smaller than this, it's a partial response, and if it's bigger than this, it's stable disease, or it's not a response. Okay, where did that number come from? Doctors are always so, they're always telling me on, tumor board, there's like the new drug, it's got a 40% response rate, that's great. 40% of people respond, okay, but why is that the cutoff for response? Well, it turns out the reason it's a cutoff for response is that in 1976 in Mayo Clinic, there was a dinner party. And at the dinner party, there was this old man, Charles Mortel. He invited 16 of his friends over to his dinner party, and he put a mattress on the dining table, and he put 12 marbles of different sizes on the table. And then he put foam rubber on top of the mattress, and he asked everyone to take measurements of these marbles or spheres. Here's what he did. 12 solid spheres. They range inside from 2 to 14 centimeters in diameter. They were covered up with foam rubber. The foam rubber was ½ an inch thick to approximate the skin and 1.5 inches thick to approximate the abdominal wall. This is 1970s. We may have to make it a little bit thicker these days. Everyone has to bring the ruler or caliper that he employs in clinical practice. It says he employs because there's no women, it's only men at this dinner party, because back then it was a sexist field. Okay, so only men, dinner party, calipers, foam rubber, measuring marbles. Why the heck are they doing this? They're doing it because Mortel's got a little trick. 2 of those spheres are actually the same size, 5 and 6, and 7 and 8 are also the same size. He didn't tell everyone that. So now he's asking a very interesting question. How often do 2 different doctors think the same size tumor is actually different in size? And how often does the same doctor get fooled? And he basically creates 2 sets of cutoffs, a 25% bidimensional cutoff and a 50% bidimensional cutoff. And he shows that if you use a very small cutoff, 1 in 4 times the doctor is fooled. But if you use a little bit bigger cutoff, it goes down to about 1 in 20 times the doctor is fooled. He likes 1 in 20 because that's close to the real p-value. So what Mortel is saying is that if we use this kind of 50% bidimensional cutoff, we'll only be fooled 1 in 20 times and think it shrunk when it didn't shrink at all. That's his question. And that cutoff was chosen because that's what men could feel through foam rubber back in the diggities. And that's the same cutoff we use for response to this very day. In fact, well, you're going to say, hey, wait, you said 30% shrinkage, not 50%. But the answer is, in the original WHO, they measured in 2 dimensions. And in 2 dimensions, 50% is a third of the volume, whereas in the new RESIST, in 1 dimension, a 30% reduction is a third of the volume. We use the same cutoff that this old dinner party led to in the 70s. Okay, why do I tell that story? I tell that story because I think we should take it with a grain of salt. When somebody tells you a drug has a response rate, know that response is some tumor shrinkage, but it was arbitrarily picked in the 1970s because that's what you can feel with foam rubber. And now we have CAT scans and all these other things. We never updated that analysis. Okay. Maybe I'll just do one more thing. Or any questions so far? Okay, last thing. I don't know, we see a lot of patients like this. This is kind of not an actual patient, but a representative patient. A 69-year-old woman who has a really good performance status, and she has lung cancer. She got carbo-pem-pem, we give a lot of that. And then unfortunately, that stopped working. She's got new liver and bone lesions. And we send the foundation medicine, and she's got KRAS G12C. So what does everyone want to give her? They look in this algorithm, it says KRAS mutation, they say give that other treatment, and then finally she gets sotorasib. We wrote a couple papers on sotorasib. That's one. Sotorasib got approved in 2021 based on this Codebreak 100, where they just took sotorasib and gave it to a bunch of people. They didn't have anyone to compare them against. And what they found was that 36% of the time they had an objective response rate. But now you know what response rate means. It means how much tumor shrink that old men can feel it through foam rubber. So only 1 in 3 of these people had their tumor shrink so much that an old man could have felt it through foam rubber. That's all they're telling you here. Stable disease is 44%. That means the tumor didn't shrink enough to feel through foam rubber. It means it barely shrunk at all, probably didn't do anything of value, I think. They call this disease control rate. I think that's a distortion. We should be talking about this and not these other things. Now, I think like if you look at all the chemistry, there's a lot of people here in this university who do all this fancy chemistry stuff, and they would say that like this is a very clever drug because like the molecule is like a basketball, and this drug, it's like palming a basketball. It's like very hard to like grab it, but they found a way to grab it. Well, that's fine, but the patient doesn't care about this kind of stuff. The patient just says, is the drug going to help me? And what's the side effects? They don't care about this kind of molecular picture. And to be honest, I don't care about it either, and I don't like listening to talks that talk about this. It kind of bores me. The drug company talks about the waterfall plot. This means the single best subsequent scan. So these people whose tumor got bigger, the single best subsequent scan was, unfortunately, the first scan shows it's growing. This drug not doing anything for these people. For these people, it starts to go down, and the PRs are shown in green. The people who had the 30% response rate confirmed on a second scan. We did a paper just to show you that this thing is excluding something. What if you took the drug and you died the next day? Where's your bar? Oh, you're not on the picture. So, and then what if your tumor shrank on one scan, but by the next scan it had exploded? Oh, they're not going to show that on the picture as well. And so we actually proved in a paper that these pictures are distorted and they look about 12% better than what the reality is. So it's a little bit of an optical illusion. Okay, I'll skip that. I'll skip some of this. Okay. So people like this drug. They like the drug because, you know, it had 1 in 3 people had the tumor shrink that 30%, and that lasted for about 11 months. But if you look at all the other kind of molecular drugs we give, like osimertinib, well, that lasts for like more than 3 years, and here you're lasting less than 1 year. So it kind of looked like it was a suboptimal drug compared to the other targeted drugs. They finally did a randomized study. They took sotorasib and they compared it against docetaxel, which is a really cheap and old drug. And here's what they found. They found that progression-free survival had a 1.1 month gain. 1.1 month. So we're giving this extremely costly, tens of thousands of dollars a month medicine for 1 month progression-free survival. And if you look at overall survival, it's a fiasco because actually it doesn't improve survival even 1 day, and the curves cross. And it looks like it doesn't even make you live longer compared to docetaxel. So to me, and the last thing I'd say is, they show that waterfall plot. The people getting docetaxel, this is what it looks like. The people getting sotorasib, there's more people whose first scan has massive tumor growth. In other words, this pill, for some people, it doesn't work at all, and they have rapid progression, whereas docetaxel doesn't have that at all. So there's some people who are going to die faster because of getting this pill, for sure. Okay, so there are lots of problems with this study, but I guess I'll summarize by saying, to me, I think, why are we doing this? I don't know what we're doing here. This drug costs a fortune. It doesn't make you live longer. It has really bad side effects. There's tons of problems with this study, which I could detail, but it will be very boring. And this is the county hospital. And even if you think it works, even the people who are proponents, they're going to say it's 1 month benefit in PFS, not even survival. We could do so much more with that money. If you had an extra nurse on the floor with all the money that we spend on these drugs, it would be better. If we had an extra care worker, it would be better. If we had an extra social worker, it would be better. We could do so. If we had more pathologists, it would be better. Better, a few more staff around the hospital. So to me, I think the biggest problem I see at a county hospital is that we're not prioritizing what we should be doing in a sensible way. All right, I'm going to stop there, if that's okay. And I'll just point to some future things to look at. Well, if you're interested in this talk, I run a YouTube channel, and it has a whole video series on how to read and appraise medical research, where I talk about mostly oncology studies. I host this podcast called Plenary Session, which is on the iTunes, Apple Podcasts. And I wrote this book called Malignant, which is also in audiobook format, where I painfully narrated the whole audiobook, so you'll hear my voice for 7.5 hours if you ever want to listen to that. All right, well, thank you for the opportunity to speak to you all. It's good to be back for year 3. Hope to be back for year 4, and hope we do it in person for real. All right, thank you. Any questions?
I have a couple.
Yes.
So just like the magazine, you did a very early kind of example of that curve being the same, the not statistically
Right.
One. So the FDA approved that.
Yes.
And so is that like a regulatory capture thing likely, or how is that?
Yeah,
How is that possible?
that's a great question. Yeah, how do these drugs get approved? Yeah, and the same thing I showed you was the majority of the drugs on the market, we don't know if you live longer. So, I think there are some structural problems. One structural problem is the FDA. If you go to work at the FDA, they pay you a very low salary. And I did my fellowship at the NIH in DC, and a lot of people I know who train there go to FDA because it's literally across the street. It's very close to us. They pay you a low salary, but within working there for 5 years, 7 years, 3 years, 10 years, a lot of people switch to go work for pharma. So they got this revolving door, and we did a paper where we show about maybe 2 out of every 3 people who leave go to pharma. But that's a problem because to me, if I knew there's a 66% chance that I'm going to go work for University of Pittsburgh, I'm not going to say bad things about University of Pittsburgh. I'm more likely to play ball. And I think that's one reason why they approve these drugs even when they don't know. The second reason I think is that there's a broader community of oncologists who are experts, and even to some degree some other groups, but particularly oncologists who are expert oncologists who go and tell FDA you should approve these drugs. And if you look up those oncologists, you'll find that they often take $100,000 or $200,000 a year in payments from pharmaceutical companies. So to me, that's a huge problem where the people advising the FDA and putting pressure on them are really kind of beholden to the companies. So that's another type of regulatory capture. But I agree with you that I think the reason why we approve drugs that we don't know if they really work is regulatory capture.
And I guess it sounds the kind of follow-up to that is, even as a nurse here at City and County, there's, we don't get to even go to the dinners that oncology, we got some boba today, and that's about the extent of what we get. So you would think it would be very insulated from a process, City County would be sort of insulated from that sort of same regulatory capture thing. And I guess the whole point here is here we are in a county hospital, we're still sort of suffering from that same kind of either mindset or regulatory problem. Mm-hmm. What is it here? Is it just the same thing that there are the pharmacists little tricky, but yeah, what's going on in the city and county that you would think would be a little bit more insulated because of those very strict rules about, you know, gifts and stuff like that, that maybe it's much laxer in the federal government or that.
Yeah, that's a good question. I guess I would say that I think maybe about 25 years ago, drug companies would pay like doctors to go to Hawaii with their family for, you know, these kind of lavish gifts. And then people found out about that. There was all these news stories. People got angry and they said, let's cut back on that. We can't. Drug companies can't be paying for your golf weekend. And a lot of places put rules is they can't be buying you lunch and they can't be giving you free pens and they can't be giving nurses, you know, boba tea or whatever. They put all these rules. But to me, the rules punish the wrong people. I mean, they're punishing, like, the problem was never that the nurse was getting a free sandwich in some back room and that was not the problem. The problem is that the expert who works at Harvard is literally writing the guidelines and receiving $250,000 a year in payments from Celgene. They didn't tackle that problem at all. They just punished the small people. They didn't punish the big people. And I think that's the thing. Like, all the fixes are like token. They just want you to think we're doing something. And so we got all these rules about who can come to, I don't know, our clinics and talk to, so many rules. But the big problem is the expert writing the guidelines, there's no restrictions on this person. And that to me, I don't know, it's like so how does it happen? I think, you know, powerful people don't want to be regulated, so they regulate people who are not powerful. That's what happened. Yeah. Yeah. All right. Well, thank you all. Hopefully, next year we'll be back in person? Okay, good. Okay, thanks.